So good evening, everyone. My name is Louise Cohen, and I'm the CEO of the Primary Care Development Corporation, or PCDC. We're excited to be your hosts tonight for what we think will be a really interesting conversation. We're glad that you all are facing us because we get to see this view of New York, which is pretty astonishing and lovely out there. This is our third annual Primary Care Summit, one of our activities that we call an innovation circle, which is a way of bringing people together, convening folks to have important conversations about primary care and what it is that we think primary care needs in order to grow and develop to fulfill the promise that we all know primary care has. We want to thank our sponsors for the evening, Athena Health and Custom Computer Specialists, who helped make this event possible. Our mission at PCDC is to provide, expand access to quality primary care in underserved communities through investing capital to increase primary care capacity, providing training and technical assistance to improve how primary care is delivered, and advocating for public policies and funding to ensure strong, sustainable primary care. And we know that you all share those goals with us. What's going to happen tonight is I'm going to set up the conversation a little bit, and then we're going to speak a little bit, we'll have Chris Kohler speak a little bit about the Rhode Island experience and increasing the share of spending that goes to primary care. And then we're going to engage the panelists in an interesting conversation. And I know it will be interesting because I've actually had the opportunity to speak to each one of them about this topic. And for each one of them, I felt that we could have spent an hour or two just with each one of them separately. And then we hope to have a robust audience participation. So please feel free to write down your questions and keep them ready. And then after that, there's going to be another networking opportunity out there, and where you can mingle with ourselves, our sponsors, and our panelists. So what's our premise for this conversation? Our premise is that primary care is the foundation of our healthcare system, and that there is overwhelming evidence that it is essential to better outcomes, lower costs, healthier families and communities. And without sufficient primary care, our communities, particularly the most vulnerable ones, will remain sicker and poorer, and the disparities will increase. We know that primary care reimbursement, whether it is retrospective in a variety of forms or prospective in a variety of forms, is an important component of keeping the primary care system strong. We know that there's a wide variety of different forms of primary care reimbursement. And in the United States, and certainly in New York State, there is an enormous conversation about value-based payment and what primary care must do and how it will be measured in order to receive those payments. We know that primary care is required to provide evidence-based medicine. And we also know that in order to provide every single piece of evidence-based payment, a primary care provider with an average panel of 2,000 patients would have to spend over 17 hours a day just doing the recommended acute, chronic, and primary care that would lead them to have the best possible measures. And we know that, and people may have read Larry Casalino, one of our panelists, one of his articles came out in Health Affairs Today, which talked about the kind of metrics that primary care is being asked to, the numbers of metrics that primary care is being asked to collect, and the cost that it is, the burden on the primary care and other providers. But what we don't think is happening enough is a conversation that says, in order for primary care to provide this high quality care, to transform itself, and to report out results and manage all of this, who should bear the costs, and how much should primary care be reimbursed for this? So we know that in the United States, the spending on primary care is extremely inadequate. For our $3 trillion that we spend in this country every year on healthcare, only 5%, more or less, goes to primary care. 5% of the $3 trillion spend. And it turns out that we don't actually really know how much goes into primary care because there is no uniform measure on this. It's not calculated at the federal level, most states, and certainly in localities. So there are a couple estimates nationally that have been published, and they're pretty divergent. But what we believe is it's more or less 5%. And what we actually also believe is that at the minimum, this spend needs to be doubled. Now, you could argue it could be tripled, it could be a little less than doubled, but somewhere in that neighborhood, PCDC believes that primary care needs to have at least a 10% share of the healthcare spend in order to do all the things that primary care is being asked to do. So we're going to be talking a little bit about that today, whether we agree with that, whether we think there should be some regulatory requirements about the amount of spend for primary care, and how we might get there. And today we have an extraordinary set of panelists who all work in various ways to support either in the primary care system or to support it. Their bios are in your program, so I'm not going to go into great detail, but I do want to just mention a few things. We'll start with Dr. Larry Castellino, who is the chief of the Division of Health Policy and Economics at the Weill Cornell Medical College. He's a primary care physician with over 2 decades in private practice, particularly in small practices. He's authored some important studies, including the one I just mentioned from Health Affairs Today, or recently, and then the recent RAND study on the effects of healthcare payment models on physician practices. We have Lindsay Farrell, who's the president and CEO of Open Door Family Medical Centers, which is a federally qualified health center serving over 43,000 patients in 5 locations in Westchester and Putnam counties. She is a level 3 patient-centered medical home and one of the nation's top-ranked community health centers for clinical outcomes. Dr. Sherry Gleed, who's New York University Wagner School of, the dean of the New York University's Wagner School of Public Service. She was a top healthcare official under President Obama and a senior advisor on healthcare policy for Presidents Bush and Clinton. She's a highly regarded expert on the U.S. healthcare economics and policy and the author of several books. Chris Kohler, who is the president of the Milbank Memorial Fund. Previously, he was the health insurance commissioner for Rhode Island, where he led a successful initiative that nearly doubled the share of primary care spending. And Troy Oshner, who's the deputy superintendent for health for the New York State Department of Financial Services, responsible for regulation of all health insurers and related entities. And I actually do want to point out, because it's on his official bio, that he plays in a Zydeco band. I don't know about the rest of you, but that is fantastic. So we're going to jump into our conversation. And what I want to do first is because I think there is a best practice here. There is a history of how we can, in fact, double the primary care spend. So I want to ask Chris to speak for just a few minutes about his experience in Rhode Island, what he did there, and why he did it, and what the outcomes were.
Great. Everyone hear me back there? Is the mics being put up? Yeah? Okay, Dan. I got the thumbs up from Dan. That's all that matters. Thanks to Luis for hosting this, and also to the folks at PCDC for teeing up, and not only this topic, particularly about investing in primary care, but for the work around building the primary care infrastructure. It's one thing to talk about it. It's another thing to actually go do it. And I was looking at the attendance list. We have a lot of folks who are involved in this endeavor in various places today. We have people who deliver care. We have people who administer the care. We have folks who research about it. Give a special shout out to the folks from New York State government and city government who have to deal with competing forces and look for ways to referee and look out for the public interest, which isn't always easy. So what I'm going to do is talk a little bit about this idea of investing in primary care and what we did in Rhode Island. I think there are some lessons that are applicable. Troy and I were talking about this beforehand, but it's a different sandbox here, much more complex. You know, we have 1 million people in Rhode Island. We have a few plans. Troy's got them falling out of the trees. So that's why he plays in the band, is to give him some relief from some of that effort. Quickly, the Office of the Health Insurance Commissioner was created in 2005 in Rhode Island, and I really think you have to, we've been successful for the commercial market in, as Louis said, almost doubling the amount spent on primary care in Rhode Island. But to understand why, you actually got to go back to the law. So commercial health insurance in Rhode Island is regulated with a fairly broad set of standards that includes a statute that says that health plans shall contribute to policies that improve the access, affordability, and quality of the healthcare system. And as my lawyer said, Chris, that's a shall, not a may. Your job is to help them figure out how they do that. And what we determined through a collective process is that where we wanted that, the health plans couldn't create all the things you need to improve quality. They couldn't create a culture of health. They couldn't reduce smoking. They couldn't improve asthma chronic care by themselves. But it turns out they could invest in primary care. And so I'm going to just sort of describe how we got there and what we did along the way. we discovered that the accountability mechanism in Rhode Island for commercial health insurers was rate review. We had comprehensive rate review. It was a gate that they passed through. And the question that we asked was, if that's the place where health plans demonstrate what they're doing to meet their statutory standards, what is it that we want them to do? We had an advisory council established by statute that composed of consumers, businesses. The health plans were there, the providers were on it. And we said, okay, here's evidence from Commonwealth's high-performing health system. Here's the evidence around primary care, all this other stuff. What makes sense for the health plans to work on that's directly in their control? And with a little bit of encouragement and some data, because I had seen the evidence, some of it published in the Millbank Quarterly, by the way, around the importance of primary care and sort of just the enormous discrepancy in the U.S. Compared to any other place, and how much and the portion that we spend on primary care. And Professor Gleed would be quick to say that association is not causality. However, there does seem to be a pretty strong association, and Barbara Starfield worked on this too. She did think that she found some causality. So what could we do to address that in our little place in Rhode Island? We said first we benchmarked. We went out and said, what do other countries spend? What does it look like in the US? What do high-performing health systems? We got very rough approximations. Europe, some countries somewhere north of 30. Kaiser, somewhere in the teens. Geisinger, 11 or 12. The old line staff model HMOs. Very rough numbers. And we knew that we were around that 5, or that commercially we were around that 5. So we actually went to the health plans and we said, give us your claims data. Troy has that authority. If he says health plans, give me your stuff, they have to give him his stuff. It's great to be the insurance commissioner. And lo and behold, as near as we could tell, our numbers were around 5 or 6%. So we just, with the advisory council, said to the health plans, we don't know what the right number, it was a lot like what Louise is saying, we don't know what the right number is, but chances are you could go a point a year and you wouldn't be overspending on primary care. And you guys understand the math of this. A point a year is, in terms of total percent, that's 1 point on trend. That's, Troy knows, that's what health plans do all the time in terms of actuarial assumptions. That's just they're just kind of looking around saying, let's add a point here or there. For a health plan, for a primary care doc, you've just put in 20%. You just increase the money that's going into primary care by 20%. So there's an enormous leverage factor to it. And we made a decision that the health plans would be held individually accountable. So wherever they were now, we found out they're only about a half a point or a point. There are, depending on how you count, 3 or 4 commercial health plans. And we just said, every year you've got to go up by a point. And we gave them a 2-year run-in. So we gave them a year to kind of ramp up. We defined primary care for them. We did it collectively. We did it the easy way by physician specialty, family practice, pediatricians, internists, no internal medicine subspecialties, no OBGYN, and nurse practitioners are not independently licensed, so they fall under the physician billing code. We did trial and error with the plans. We met with them every quarter individually to just kind of develop a reporting template, and that evolved over time. And then we made adjustments. None of this was regulatory. We issued guidance so that we could make, frankly, mid-course corrections, because they came back and said, well, what if we spend it on this? And what if we spend it on that? And we would take it to the advisory council, and they would, in front of everybody, they would make recommendations that would hold to folks. So the advisory council early on said, we don't want to see this increased trend, which was, I will say, a feel-good measure, because I, as the commissioner, wouldn't really know whether it was affecting trend or not, but it put the health plans, it gave the health plans cover. I'll get back to that in a moment. And they said, we don't want to see the increases go to fee-for-service. We want to see it be some form of payment reform or incentives. So the goal here is not just to increase E&M codes. The health plans were on board with all this. This is important. This was not done shoving it down their throats. They were a little bit skeptical that we could pull it off. But these are chief medical officers. They've seen the same evidence. They are looking for ways to say, they know the market failure is out there. They're looking for reasons to say no to other providers, or less to other providers, so they can say more to primary care, so long as we weren't overly prescriptive with what they did with it. And we gave them big buckets. patient-centered medical home, multi-payer patient-centered medical home, EHR, pay for performance. We didn't get overly prescriptive. And we had them report back every year on what they were doing. So that means every once in a while they would say to a group with monopoly power, no, we can't, one of the reasons we can't give you everything you want is because the commissioner said we got to put some into primary care. And, you know, well, I'll get to what the results were, but they didn't flinch, you know, lo and behold, they could pull this kind of stuff off. So 5 years in, what have we found? We've moved the average spend from 5.8 to 10.8 for commercial fully insured. Has resulted in roughly a doubling of the amount of money going into primary care. It's actually a little bit less because what we don't have is self-insured, and so we don't know what's happening in the self-insured market, and we don't have Medicaid and Medicare. So while this is nice for commercially insured, and it's important, and we think there's probably a halo effect or a trailer effect for self-insured because health plans largely pay the same way for their self-insured because they're the administrators. We don't know exactly what's going on there. Troy's working on preempting ERISA or getting ERISA so he can get all the data himself. But until then, we can't get the ERISA data. And so that's the critique of this, that it's systemic, but it's not all the way. And meaning that we don't know what's going on with Medicare, Medicaid, and self-insured. But what we do know is we plowed a lot more money in. We know where the money went. Most of it went for patient-centered medical home assistance. It also went for pay for performance, and then a little bit for EHR in our health information exchange. We have a regional health information exchange. We said money spent to support that counted towards the primary care spend. Another one kind of mid-course correction so they could get credit for it. And we know that different health plans did different things. Blue Cross was all into their own patient-centered medical home plan, so they wanted to do that, and they saw this as a way to put it in. United wanted to do pay for performance. We weren't going to get in the way of that because we didn't think it was worth it to get that prescriptive. What have been the results? We had lofty goals. We were going to monitor ER admissions, ambulatory care sensitive admissions, physician satisfaction, premium trend. Myself and my successor one are unable to do that in a systematic way. What we know is that we created the space to give birth to one of the most successful primary care-driven ACOs in the country. So their CEO says we couldn't have done this without the primary care spend requirement. We nurtured a successful multi-payer primary care initiative. Blue Cross is very satisfied with their own patient-centered medical home plans, so they continue to do that. And I think one of the most interesting things is that between 2011 and 2014, bless you, the state with the lowest commercial premium trend rate of increase in New England was Rhode Island. Again, associative, not causal. Blue Cross notes that they had a number of favorable contracts that were done. But we didn't lose any specialists. We didn't have them run for the hills like people said that they were going to do. We were still able to recruit. I'd like to get some better primary care physician satisfaction. We didn't have primary care physicians driving around in BMWs in the hospital parking lot, another fear that people had. We created space for people to make the investments in primary care that are necessary to do this work. So I've probably rambled on way too long, but I think there are lots. We'll get into what the lessons are for New York State as you do this work too.
So that's a pretty significant, gauntlet to throw down. A 1% year-over-year spend increase on primary care, with the idea that it goes towards improving primary care in a variety of different ways. Primary care isn't measured uniformly today. That's one of the first things. Do we think that that's a stumbling block in order to get to this kind of regulatory environment that we might need? Anybody want to take that on?
I mean, it's certainly a stumbling block. It doesn't necessarily mean that it's a I don't know what the word is. It's not a cliff, but it is something that we have to, that I think you had to deal with, and I think we all have to deal with, which is as soon as you put some money on the table, there is going to be a food fight over what exactly counts as primary care and how exactly you measure whether it's going to primary care. The same kind of fight I remember having around the minimum loss ratio, and lots of debate about whether you're actually seeing something real happening and whether you're seeing recounting the same things in different ways. These are These are things that happen every time we do a regulation. It doesn't necessarily doom it. I think it's just something that we have to address as we think about it.
How many hospitals are in Rhode Island?
12 or 13.
Do you want to say something about that, Lindsay?
It's a metro
No,
area.
just pointing that out. I don't know how many hospitals we have in New York, but it's a lot more than 12 or 13.
So, but the primary care spend, was it only on community-based primary care providers, or were there hospital ambulatory care systems as well?
So we calculated based on tax ID. So the hospitals had, to the extent the hospital, a combination of tax ID and specialty. So if you build an E&M code, you couldn't get away with billing the hospital. You had to bill the specialist, and that's how the health plan pulled it off. So hospital-owned physicians got credit to the extent that a hospital-owned physician was billing an E&M code, or the hospital was billing an E&M code. They got credit. Money that the hospitals got in terms of their through their contracting. We got this question a couple times. What if a hospital says they're going to spend some of my money on developing their integrated care system? We said no. You know, it's got to go to the provider.
Great.
So I think that measuring, clearly coming up with a uniform definition nationally, a hard thing to do, but still necessary if you're going to actually have some comparative ability across states and nationally to say this. But I think, and we'll come back to this at the very end, but I guess I want to pose the question now to see if there's any initial feelings about this, which is, is this a regulatory, advance that should be replicated? Should we try to say there's a trend increase in primary care that we're going to require at a regulatory level to see whether it comes through a federal regulation or whether it comes on a state-by-state regulation? Right now, there's no minimum requirements for primary care. Should there be something that says we must increase the amount? And this doesn't, and I'm not asking for, a specific piece of legislation or regulation, but I'm asking, do we think that that's a good idea, or will it have some unintended consequences if we do that nationally?
Well, I mean, I can chime in here. Again, Troy from Department of Financial Services, DOFS, or doofus, as we like to say. But one of the things that we're working on, and really the key people are Hope Plavin and Foster Gueston, who are somewhere out there. I think they're in the back there. But we've been working on on SHIP. That's SHIP with a P. And the State Health Innovation Plan, and there's as you may probably, it seems like a pretty knowledgeable crowd, 5 different buckets. One of those buckets is working on integrated care, and in particular, we've been working on advanced primary care. And as part of that, well, I'll just take a step back. As a regulator, we come at this from the point of view, we have to review and approve rates. And we have people constantly complaining, as you can imagine, we're responsible to the public, that I can't, we had individuals, and the yellers don't bother me so much, but the guy from Utica who operates the cleaning service, who was crying to me that his rates were going up 14%, and he runs a small business. He's had coverage for his employees for a gazillion years, and he can't keep doing it. His business isn't going up that long, and what is we supposed to do? So come at it from the point of view of what we all know is that it's just unsustainable, it's dragging down business, et cetera. How do we meet the triple aim of the State Health Innovation Plan? Improving access, improving quality, and lowering costs. And so I think we all know, and we're bought into the concept that primary care is key to making it all happen. Integrated primary care, absolutely key as a basis for all of this to work. And when we first started doing this, I remember asking some of the health plans, because there's a lot of studies out there showing how cost-effective primary care is compared to specialty care. And they were all aware of it. And I said, well, why aren't you doing more to spend on primary care, and I have a variety of answers, but what I felt were the most honest answer is because we're not paying more for primary care because we got to cut somewhere. We got a lot of pressure from our clients to keep costs low, and we can't cut hospitals. We can't cut.
It's economic power.
It's economic power. It's negotiating strength.
Sherry's right.
And
economist.
you know, that's we probably already all know that. So, and then, but I think that there is, as Chris pointed out, there's interest in trying to create the space to be able to make those investments. And so part of what we've been doing on the advanced primary care work group that we have going on with the Department of Health, and again, Foster's been a key leader in all of that, is to create a set of standards around what it is we want to build. And part of that comes from, you know, when we talk to providers, well, why aren't you doing more integrated care? Why aren't you doing more practice transformation, et cetera? One of the responses was, you know, I'm running a doctor's office, primary care doctor's office, and I'm dealing with 9 to 12 different insurers. They each have slightly different measures. They each want different things. I can't manage that realistically. We need a common set of measures that we're going to look for, and then we need to get insurers to pay for it. So we've been doing a lot of work, and I'm certainly not the expert on getting those measures. I know one of the big things is trying to align the measures we're talking about with the recent measures that just came out from CMS. But the idea is to get a general buy-in from payers, providers, et cetera, on what the measures should be, and then the next step is how do we pay for it? And certainly Chris wrote the playbook on how you do it. That, you know, insurers, part of a national organization of insurers all around the country, talking about the playbook that Chris wrote. In New York, I think that there's an interest in you know, we want payers to pay for it, but we want the ideal is to give them carrots at least. That's the first impulse, is to try and make this appealing, creating the value proposition, the return on investment for why it's going to happen, and then making certain regulatory changes, relief that we can do to try and make it easier for insurers to make those investments. So things like looking at our rate review, we have a very similar expansive rate review law in New York, and one of the things is to allow some key payments that we want insurers to invest in primary care. The practice transformation payments, which in the initial instance helps to give the resources, IT and other resources that a provider is going to need, helps them make those investments. Also time that they're going to need in retooling. And so we want to help them get those practice transformation payments made so that the providers can do that. And then secondly, care coordination payments. So once they're starting to do that care coordination, paying them for the kind of stuff that they're not currently getting paid for, eventually moving towards real value-based purchase, value-based payments where there's shared savings and you know, all the stuff that goes with that. So I'm sorry if I talked too long, but
all good. So carrots, not sticks, recognizing the impact on rates and this idea of having to cut elsewhere. I do want to point out that I think something I read about Rhode Island mentioned that there was, over the same 4 years, a 15% decrease in total cost of care. Causative? Wow. Associative?
I'm not sure. You didn't see that source coming from the Office of the Health Insurance Commissioner. So we go, you know, it's clearly, well, I want to get back, I'm not going to take, I won't go near that one. What I want to point though is because it's, the professors here will take me to task, you were trying to make a case for measurement. It's inconceivable to me why we don't have a slice in every medical expense pie that doesn't lay out primary care. And primary care advocates should get over their tribal battles and help make that measure happen. You know, to think that pediatricians and family practitioners and internists are too busy scuffling over crumbs as opposed to agreeing on a common definition, that we can just see that slice. We improve what we measure.
Right.
We got to see that slice in there.
And politics works around what we measure too. So if we can't say how much it is and how it's changing over time, we can't study it, we can't look at what's going on. I actually would say that's, at the national level, that's probably the most important thing to do, even before you try and mess with the payment. I mean, we just did the Medicaid primary care bump. Does it have a long-term effect? Is it going to change the system? Hard to believe. Maybe a nice thing, good thing that we did it, but if you really want to see what's going to happen over time, I think you want to measure it and watch it.
Okay, so I think that's what we're gonna. I'm keeping kind of a list of policy recommendations for the last part there, and I guess I want to turn just briefly to this question of, well, to be honest with you, I've run primary care, and if someone said to me, "I'm going to double what I pay you," I know what I would have spent it on. So, Lindsay, let me ask you, what would you spend it on?
Oh my God. Well, information systems. And what's so challenging is that they're expensive, and then you need smart people to support them and to do the analysis. And now we've got incredible cyber security risks, and so there's all the associated expense with that. So information systems are really important, and the people to support and do all the analysis. And I think your article said $50,000 per provider. And that is probably, I didn't read the article, but that's probably based on how many measures. But I mean, how many measures? Oh my goodness. I think at Open Door, we're probably measuring on an ongoing basis, probably 30 things on a regular basis. And then we get lots of different requests to measure other things. And so I would imagine that $50,000 number is probably per provider, probably a reasonable number for those measures. And yet,
just the cost of measuring, I kind of want to point out, not the cost of doing anything clinically about that.
And the systems. Then there's the whole provider education and transformation piece and clinical leadership, because everybody is really busy and they have a long list of things that they need to worry about. There's stuff coming into the EMR all day long that our providers need to attend to, and they're exhausted. Then there's patient access, right? We've got to deal with urgent care out there now, and the last thing we want to do is lose our market share to urgent care, which is popping up, from large hospital systems all across our marketplace. That could indeed erode our patient base, so that's a challenge that we have to confront. And then there's the whole issue of, how we weave all of our payment streams together. We were up in Albany fighting for our uncompensated care pool. We take care of a lot of uninsured patients, and there's some problem that money isn't going to appear. And we've already done the work. That was from 2015. And that will send our organization into a deficit position for work that we've already done. And we're worried about 2016, and we're worried about 2017. So this whole notion of getting paid for everything sort of after the fact is really very challenging. And then there's care managers. We need one for every provider, truly. There is so much work that the physicians and the clinical support team just can't do in the context of the patient visit. And so we need lots and lots of care management resources. And then there's space. So we've staffed up, we've got new technology, we've got new care coordinators. I have no place to put anybody, and I can't afford the risk of taking on too much space because, heaven forbid, we get shorted on our uncompensated care money. So all of that is really very challenging. So would love to double the primary care spend, would love to double the amount of space that we have. I mean, we're operating in facilities that really were designed 30 years ago. And our physicians really are operating in a model that was designed 50 years ago. And so, we need to spend a tremendous amount of time in training, in education, and then we just need the resources to be able to live in a hospitable environment and work to our potential.
Larry, I don't know, thoughts on what small practices would spend this money on?
Oh, I used to have a colleague, Bob Hurley, who used to say, if you give physicians more money, they'll just go buy a bass boat. I don't think it would necessarily be such a bad thing if primary care physicians put some of the money in their pockets. Honestly, I think that the pay gap is so much now. I hate to say it, but I co-direct a healthcare leadership fellowship program at Cornell, and so young faculty, young and mid-career faculty, apply to be in this program. And we're in our 5th year now, and it's just been borne in on me, reluctant as I am to see it or say it, the quality of the people that are applying to this program from the highest paid specialties. They're different than the people that are applying from primary care. I don't think that was so much true when I was choosing a specialty, though I will say that when it came time to choose specialties, the attendings at UCSF where I was would ask, "So Larry, what are you going to do?" And I said, "I'm going to do primary care." The ones who family practice, the ones who liked me said, honestly, they said, "You're too good for that." And the ones who didn't like me said, "That's about right for you." And most of them didn't say it quite that bluntly, but I think there actually is a talent gap now. There have to be with the pay gaps as huge as it is. So if some went into people's pockets, I wouldn't mind that. But I think that small practices on their own, other than giving themselves more money and paying their staff more money, they can invest in EHRs. They can invest in little things. They can't do the big kind of care coordination things that we all have in mind, right? They can do it through sharing resources, such as an IPA. But the IPA itself needs to get some money then, and there's some question where that's going to come from, because of course the physicians don't want to get in their pockets. They don't want to give it any of their money. But I guess I want to step back for a minute, and I think I'm not sure how much should we spend on primary care is really the right question. I think the right question is, what's the best way to improve our healthcare system, right? And I think that sometimes when we talk about this, we jumble too many things together, in my opinion. So I would say there's short-term and long-term, or let me just say short-term pragmatic and long-term utopian solutions. And overlaid on that is what practices, say little practices, can do for themselves if you gave them more money, and what big things could do. And then there's all kinds of questions, market versus regulation, antitrust. So let me be a little more specific. What would be the greatest healthcare system probably that we could have? Let's say if payers just gave providers, they say, here's the money, right? You take care of the patients any way you want, right? If you see that Mrs. Jones is getting admitted to the hospital every 2 weeks during the summer because she has congestive heart failure or COPD and she doesn't have an air conditioner, get her an air conditioner. Pay her electricity bill, right? It's a lot cheaper than one ED visit for the whole summer, right? You're not going to do that unless you have that kind of payment scheme. Similarly, you don't decide what percentage of primary care physicians should we have in our organization in some arbitrary way, or how much should we spend on primary care, or who should provide primary care, or should it be done face-to-face or by email and phone? The organizations in a well-functioning system, where you're giving them the money and doing some pretty good measures of quality and patient experience, they would work that out for themselves, right? So that would be the utopian solution, right? And back in the 90s, when we had full risk capitation in California, that's what we used to talk about. This was what we could get. This, one problem with, there's many problems in getting from here to there, but that solution ignores market power, right? And so the ideal world would be you'd have organizations that could take that kind of money, but wouldn't be able to exert market power. And I guess the other question I have about that utopian solution is these big organizations that could take that risk and could put in all kinds of industrial-style processes to manage care will do very well on the things that get measured. But if our measures aren't that good, then we may be missing some things that maybe some small practices are doing better. And not to go on forever, but just to give an example, we published an article, it was in Health Affairs actually a couple of years ago, that showed the smallest practices, totally risk-adjusted, had far lower rates of ambulatory care sensitive admissions. These are 1 to 2 physician practices than 10 to 20 physician groups. Now, we couldn't compare, in this is a national study, 1,000 groups. We couldn't compare to Geisinger or Kaiser or big groups, but if we compared the rate of the smallest practices to national rates of ambulatory care sensitive admissions for Medicare, the smallest practices were still much lower. So, if we were measuring ambulatory care sensitive admissions, we could do it in a good way. then I wouldn't be so, and we did that as a measure instead of how often do you order retinal exams for your diabetics, then I would say, okay, I'm good with these good things and forget about the little ones. That's in the past. And that's what most policy analysts now think. So what I'm trying to step back, I'm trying to say that, and I'll have more to say about it later, what can we do in the short term, should we do anything in the short term to help primary care, and if so, what? And should we just see these as fixes till we get to use some utopian thing? What would get us to the utopian thing, and do we want to get that if all that we're going to do is create a lot more market power, really? So I can add some specifics to that abstract, but I've talked long enough for now.
So an interesting question, is that the way that of, you know, the place that we're actually trying to get to, whereas we just essentially give physicians funding and say, we expect, you know, to see, you know, fairly significant outcomes in terms of
And just to be
total
clear,
cost
you
of
can't
care
do that
and-
with
You can't do
a
it.
5-physician practice or a
Right.
2-physician practice or a 50-physician practice.
Right, it's a scale
It
question.
has to be pretty big, and hospitals have to be involved. Yeah.
So I'm nodding.
I
Any
mean, I
thoughts on
think
this?
primary care has to be pegged. Like, look at DSRIP. You know, if you look at the dollars that went into primary care through DSRIP and what went elsewhere, you'll say, oh my gosh, this is insane, right? So basically, healthcare transformation in New York State is dependent upon primary care performing quite well. And yet, I don't know what the percentage is. I just know my own DSRIP experience. You know, I'm expected to do a whole lot of work, and I don't know, maybe we've gotten a few $1,000s. You know, meanwhile, you know, all of this talent is now been hired. A lot of people left the managed care plans, and now they're in the DSRIP offices, and there were a gazillion consultants, and you know, like, let's get real here. And yet the expectations for primary care are substantial, and we won't achieve the $8 billion, right? I mean, we're not even going to be able to access the $8 billion or the remainder of the billions, right, without the performance that primary care can deliver.
Let me put some specifics on what I just said. I think that might be helpful. So short-term solutions could be, for example, gradually fix RVRBS, right? So
You might, just for
and
our
Sherry's
audience, you
gonna
want
talk
to,
about this.
okay, she's just going to explain.
So
it.
I'm not going to,
Right.
but that's something that would help a lot, right? And it's a scandal the way it is now. But I think that giving primary care physicians a bit more money in the form of patient-centered medical home things, help with the HRs, care coordination piece, that can help practices of any size do things a bit better. And so I think that's good. You know, I think the short-term solutions have problems. You know, there's a lot of box checking goes on to be a patient-centered medical home, and I think part of the reason the evidence for effectiveness of medical homes isn't so strong is because so much of it is box checking. I mean, I have a close colleague, a very good physician who works in a level 3 medical home. Cost of practice a lot to do it. He said, Larry, do you know how much my level 3 medical home helps me take better care of my patients? I said, how much? And he said, this much. You know, this is a zero. So there's that kind of problem. The care coordination fee that Medicare will pay now, I mean, it's nice. I did that for 20 years, probably an hour and a half a day, and my medical assistant another hour and a half. We never got a penny for it. So it's nice, but it adds all kinds of administrative burdens. Some practices don't even think it's worth it. So there's short-term things that can be done, but they're inefficient, you know, compared to just saying, figure out the best way to take care of patients and take care of them, right? So that's the kind of thing I mean, I guess, by short-term versus long-term. If you know, we're just nibbling around the edges right now with shared savings and quality incentives, right? They're such a small percentage of what any organization can earn, even really big ones, that they're a drop in the bucket compared to what you can get from getting big and getting negotiating leverage. So is it better to get negotiating leverage or to be efficient? It's better to get negotiating leverage. And this is what we could, this is probably the most likely outcome of what we have now is efficient providers will get driven out, and we'll just have big guys competing with each other. Maybe someday they'll compete on efficiency, but right now, you know, if you can get 3% more from shared savings and quality incentives, and you can get 100% more from more negotiating leverage, which exists in this city, which is better, which is better to do. So there's a tension between setting the payment system the way you might like it, which all we're doing now is encouraging the creation of bigger organizations. while we're trying to get more rational ways to pay, we're also encouraging really big things. And there isn't enough talk about how to solve that problem as there ought to be, I think. And where does primary care come in? If there's efficient competition, organizations will decide for themselves how valuable primary care is, and the primary care payment rates and so will go up or down. With inefficient competition, I think primary care physicians are still going to get squeezed because the hospitals will dominate things, the specialists dominate the hospitals, and the primary care physicians will get the kind of crumbs that we can throw to them in these short-term solutions.
I think that's the strategic question. Is the caveat that Larry put out there? Do you think that efficient competition is going to happen? And I would, as a primary care advocate, I'm not betting on it. And I advocate for high quality primary care infrastructure as a public good.
So just doing what you can do now, yeah.
Well, and positioning primary care as I mean, it's easy for me to say. I work for a foundation. I'm not looking at what a hospital's offering to buy me up tomorrow and have a guaranteed salary. So it's easy for me to spout off. But from a system standpoint, the primary care is it is the hinge to do population health, to work on the upstream issues. And we work with 18 multi-payer primary care projects around the country. We encourage them not to be threatened by ACOs because either if ACOs work, they're going to come looking for them, and if ACOs don't work, people are going to be looking to multi-payer primary care as a kind of this infrastructure solution. So don't sell out too quickly. Don't worry. Work on making primary care better, and that's where I think the investment is so important.
Do you want me to
Jump
do
in
you want
a
me to
little
go
bit
on? So, I think I love Larry's idea about the long-term utopian prospect. I do not believe we will ever get there. I don't know if he believes we will ever get there, but there are some real problems in getting there, like risk selection against some of these plans, and we saw what happened in the 90s in California. It's not an easy place to wind up. But I think, and I'm usually skeptical about everything, I think there are two sort of systemic features of our healthcare environment that disadvantage primary care in meaningful ways that we should take note of. One of them is something that Larry alluded to, which has to do with consolidation and lack of competition. And by the nature of what primary care does, because there will always be more primary care providers than there are subspecialists in any given specialty, primary care is always at a loss, but always lags when consolidation happens. So if there is a premium orthopedic surgery practice in a town in New York State, that orthopedic surgery practice, if it consolidates, can negotiate with insurers and get really high prices. The primary care doctors in that town, it's going to be much harder for them to consolidate in the same way. So they're at a systemic disadvantage with respect to insurance companies on the price negotiation piece. And that's something that's just a function of the way, because primary care is kind of the base, there just are more of them, and that's going to be a problem. And the second thing is something Larry alluded to, which is the relative value scale, which in some ways is actually, it's sort of the political equivalent of consolidation. I mean, the political equivalent of economic consolidation, and also a place where, I'm going to say, the place where technology plays into this. So the resource-based relative value scale is the way Medicare now pays doctors. Each year a committee gets together, or more often than that, and figures out the relative value of different services.
Specialist dominated.
Wait, hang on, hold on. A committee gets together, that's what they do, and they assign weights to different activities that doctors do, different services that they provide. And that weights are supposed to be based on the effort and complexity of these services. That it was a very logical model that Bill Shao figured out to do this. Over time, what's happened? Two things have happened that have really disadvantaged primary care. One is there were more specialists than primary care people on the committee, and so it's always really hard for the primary care docs to move anything along. Second, the nature of primary care is that technology does not advance in primary care at the same rate as it does in specialties. Every time a new technology comes along, they have to come up with a new rate for it. So the committee comes and hears what happens with it. Then, inevitably, what happens is it takes so and so long to do whatever procedure it is when it first comes out. That is the relative value. They don't return to it for maybe 20 years. In the meantime, doctors get much better at doing it. And so we've seen this in a number of classic cases. I think cataracts was the first one, where cataract surgery used to be paid on the basis that it took 4 hours or something to do a cataract surgery. Now it takes 10 minutes. It took 20 years until they got back to it and said, this has changed and now it's 10 minutes. Primary care is always the loser when this happens, because how many new primary care procedures are there? Evaluation and management is the same as it ever was. So there are sort of systemic problems that we have to deal with. I have another point, but I will leave it until another question.
So
Let me just say two sentences about what Lori said. One is, Sherry said, Sherry hired a woman named Miriam Laugeson at Columbia, and she's written some really good things. She managed to get into this RVRVS.
It gets,
a book coming out.
It gets
Read
released
her
this
book.
fall. Read her book. It should be mandatory reading for every primary care advocate.
I agree
We'll put
with
it
that.
on our website.
And the second thing is, I have a real life example of Sherry's orthopedic example. So I was vice president of an IPA in California for quite a few years. It was a multi-specialty IPA, about 350 docs, about 100 primary care docs. There were about 8 orthopedics practices, 2 or 3 orthopedists in each. That was our orthopedics, right? These orthopedists got together against all antitrust and said, we're not, the IPA was capitated and was paying the physician's fee for service. So you pay us X or we quit the IPA. And that destroyed this IPA that had been around for about 15 years. So, just to validate what Sherry's saying.
Well, so it's complicated in the long run and in the short run. But in the short run, the conversation in New York State, at least, certainly around the country, is all about value-based payment. And value-based payment is going to solve pretty much all of this in the short run. It's everything. It is pretty outstanding. And people now call it value-based. It's not even value-based payment anymore. It's kind of got a nickname.
They teach it at
now.
Hogwarts.
Yeah, it's exactly. It's
Do what?
it has an incantation
Hogwarts.
at Hogwarts, School of Magic and Wizardry. So I guess the question is, primary care is now expected to do an enormous amount. Larry has told us now that it costs about $50,000 per provider per year just to report all the measures. That's just reporting. That's not clinical care. That's just reporting. And value-based payment now, we're struggling with various measure sets, lots of measures across many different payers, Medicaid, Medicare. The patient-centered medical home has a whole series of measures. Macro will have its own set of measures for the Medicare system. Advanced primary care has some measures. Some of these programs have, and every payer has their own measures, of course. And I think, if I read this correctly, there were 550 measures that you counted, Larry, in this article, with another 1,700 from the federal programs.
Yeah, those aren't all for primary care physicians.
Okay,
but
say there's a lot of them for primary care physicians. That's a lot. None of us can do that, right? None of us can manage this.
Well, and the burden on primary care practices is much higher in the article than it is on specialists. Yeah. Like a primary care physician, the physician himself or herself spends almost 4 hours a week on these measures. An orthopedist spends 1.1, is what this is. Something.
Okay, so that's a significant additional impact and burden on primary care. So I guess my question is, will these new payment models ensure the sufficient ongoing investment that's needed in primary care to both offset the costs of these new payment models, in addition to the investments that are needed in what has historically been an under-resourced sector?
So we're not talking, this is separate from your spend question. This is sort of a corollary around value-based payment, correct? I just want to make sure.
It is, but I guess my contention here is that value-based payment is offered up daily as the answer to the spend question. So we have to address it.
So the precursor to value-based payment was around what do we do with patient-centered, well, there are lots of precursors, but most recently it's around what do we do around patient-centered medical homes. So let me replay the negotiation that you guys have probably all experienced between providers and health plans that we see in these multi-payer collaboratives. Primary care representative, I'm doing the work of the Lord, give me the money. Health plan, show me the results, I'll give you the money. Primary care provider, you don't say that to the ER when he orders another CT every time they show up. I don't have any money anyway. You're just going to have to do something. And so the evidence is really clear in these multi-payer projects that you cannot do pay for performance unless you define pay for performance as some structure and process. So these multi-payer primary care projects they've done it in different ways. They establish some structures, so they pay as you go along. They pay for increasing accreditation. There's a whole bunch of different things you can do, but you cannot wait for the retinal exam to be done before you pay. You have to put some of the money that Lindsay was calling for up front, and I think we've got a track record around that. And that one thing. Take a look at what John Ruggie's doing in Hudson Health Waters, what's going on in Hudson Valley. Those are all public negotiations, okay? Those, not the details of the contracts, but those histories are public record of how we've learned to get better at doing that stuff. And those experiences should be tapped into as we think about what we've learned what we want to do going forward, just like all these multi-payer projects all over the place.
I have a friend named Deanne, and she grew up on Long Island, huge shopper, and her favorite saying is, Troy, if you want to save, you got to spend. And I think that a little delay there. But I think to build on Chris's point, I think part of the discussion that we've been actively having in the advanced primary care work group is how do we make those practice transformation payments and care coordination payments? How do we make it so that we can have those investments so that primary care physicians are able to, their practices are able to make the investments and do what they need to do and have the time and the space to be able to do what they need to do in order to make to be able to do what we're asking of them in terms of the measures and the quality outcomes.
So some form of prospective payment in addition to some form of retrospective payment.
But it can still be value-based. You're just paying for structure, process, structure and process before you pay for outcomes.
And that's different from checking boxes?
Not necessarily. I mean, some box checking is okay.
Okay. Lindsay?
I have to think that this is where the interests of primary care and managed care are very aligned, because primary care has the ability to direct the care that heretofore they haven't necessarily had. Now we're sort of experimenting or thinking about experimenting with an obstetrical bundle. So how cool is that? We might actually have some power, right, in the negotiations over which hospital our patients might, be cared for at the time of delivery. We might actually have a significant say in where we direct our patients. And so I think the managed care plan is particularly interested in that scenario because our interests are aligned. They would rather see us directing our patients to a cost-effective place of delivery as opposed to a very expensive place of delivery.
So getting back to the question of incentives and carrots rather than sticks, does health economics teach us anything about what kinds of incentives would work with physicians and with provider groups to do this work? Is it, what happens if your payment is a year later when someone looks at your measures and says, well, you passed these ones, but not those, so we're not actually paying you the value-based payment?
I think, though, that, we can talk about that, but I think we need to define what we're talking about a little more clearly here when we say value-based purchasing, all right? I think what Chris and Troy were talking about in response to your question was advanced primary care, payments for medical home, the kind of things you were talking about earlier that you're doing, which are ways to get money to primary care and hopefully get some accountability for it as well. And which I'm calling a short-term solution, but that's kind of a pejorative way to talk about it. You can say it's building primary care infrastructure, it's helping save primary care, it's making care better for patients, all that. So that's all good. That's not, when CMS is talking about value-based purchasing, or I think a lot of people now, this is not really what they're talking about. They're thinking about ACOs, they're thinking about shared savings,
Yeah.
at a big organizational model.
Yeah,
right?
because
Bundle
primary
payments,
care is
bundle
so
payments.
level 2. We've
Right.
moved on to level 4.
Yeah, so, but the point is, these kind of things will help primary care, there's no question, and probably help improve patient care as well. They're not going to transform the healthcare system, and what their long-term future is would be hard to say, right? But if your question is value-based purchasing, as the Secretary of HSS is using the term, say, is that going to help primary care very much right now? I would say no, right? Because the incentives are just too small. They're not big. If primary care really is important, right, and if primary care leads to lower costs, better quality, then if the incentives were strong enough, organizations would make sure they had good primary care. But if the incentives are weak, they won't, right? And right now, when we're talking about value-based purchasing, we are talking about weak incentives. So you asked, will that be a substitute, for example, from saying, you shall give primary care 10%, or we will get more money into primary care through advanced primary care? Then I would say clearly, no, value-based purchasing as it is now and probably will be for some years to come, my utopian model aside, will not, I think, put much money, extra money into primary care practices or improve their capacity very much, a bit, but. Yeah.
Jerry, did you want to say? And then
Yeah,
we're
I mean,
going to have in
I
5
want to
minutes.
throw out a really obnoxious question. Suppose we found out that primary care does not save money in the healthcare system. It just doesn't save money in the healthcare system. It makes people feel better. They are less anxious because somebody's told them what's wrong with them. Somebody gives them a medication for a short-term illness, and they feel better. They go to the doctor, or they get a diagnosis, and they know that whether they're going to, that this probably isn't going to kill them. There's a lot of stuff primary care docs do, most of which actually probably does not save any money for the healthcare system. And I think it's possible, it's entirely possible, that we could invest as much as we like in primary care, and it would not save money for the healthcare system. And nonetheless, I personally would want us to live in a system that had a lot of primary care. And I think all of you would also. I worry that we tie our entire argument to the question of whether primary care has an instrumental value instead of whether primary care is in itself something we really care about, which we know is true because rich people pay concierge medicine, not so that they don't wind up at the orthopedist, but so that they have somebody to call at 11 o'clock at night. I really worry. We did this in behavioral health, and it was a disaster. And I just worry that pinning all of your hopes on doing this because somebody else down the line is going to save money really marginalizes you.
So hang on one second. So in about 5 minutes, we're going to open up the floor to questions. And then I think we'd like to just spend a few minutes sort of wrapping up on the policy discussion. But Chris, go ahead.
Yeah, this is a political argument. We did the primary care spend not because it was going to save money. I wasn't going to stake my position on that. We did it because it creates a base for primary care, and
Primary care is good.
Yeah, I mean, and it's. I would argue ultimately. Larry talks about the goal. The goal really is to flip the ratio of primary care docs to specialists in the country, so it reflects the rest of the world, which, by the way, costs half of what we do and has people live longer as a result of it. That's what we're working for.
By association.
So I think that's right. So I think there's a good to primary care. Some of it is in fact shown in the evidence, and some of it is shown in who we all call to try to deal with our frontline issues, the people who we know will take care of us and who know us and who we will come back to support us.
Sounding like I'm the economist in charge of the primary care.
But I think that there are some very clear, in addition to this.
Let me flip it over. I mean, here's the reason I brought it up in this context is because we talk about value-based purchasing, but we don't measure what we think is really important in primary care when we describe what value is. And so that's the challenge there. That's why I would put those two things together.
So just to wrap up the policy component of this, and then as I said, we're gonna open this up. So it seems like there's a couple key things I've heard. One of them is that if we in fact believe it's a zero-sum game and someone's going to have to lose some money, then there may be an easy way, a simple way to get to an additional primary care spend through this 1% year-over-year trend value for an insurance provider company who, for that it's not a very, someone said to me, it's just, that's not that much. Like everyone can do 1% year over year, and then, oh look, in 4 years you've gotten to 12% or whatever, which is better than we are before. The second question Sherry has raised very clearly is that we need to we need to measure this. We need to measure it. We need to measure it consistently, and it means primary care does have to be able to offer that up as a sector to say we're gonna help develop this measure so that we can measure the spend around the country and have it be something that we can look to and see as a proxy, perhaps. Maybe not. It's not the ultimate goal, right? But it is a proxy of our value, how we value primary care, and I think that's not unimportant. There is the RVU system and the question about what we can do to change that to actually rebase it in some way in a more regular or primary care friendly way, and that might mean advocating for different people to be sitting on this or thinking about rebasing things on a more regular basis. So I think that at least those are some of the questions, but I guess briefly I would just to like you to say, like, what are your outside of those, or maybe in addition to, your policy recommendations for us, and then we'll go to the floor, and then we'll wrap up.
If I may, I would, particularly for you folks in the audience, you have allies in the state government. Yeah. State's aware of this stuff. It's accessible to you. It's different from federal, is much harder. But people like Troy, like Hope, like Foster, very accessible, want to do the right thing, are looking for co-conspirators. PCDC has been very astute, I think, at working with that. Representatives from United Hospital, Greg Burke's here from United Hospital Fund. These are coalitions that can be built to advance these issues. So they need your support. Their job's really hard. They go to work with a black and white striped shirt, and they have to adjudicate between the haves and the have-mores. And if they help them do their job, deliver stories, give them attaboys. Troy would like to be doing more work on this, but he's been doing about 4 jobs for the last year at the same time, and be available to work with them to help them advance these sorts of issues.
All right, well, that's a challenge to everyone here. Anybody want to sort of have any other comments before we open it up in terms of policy initiatives and issues that we think have not yet been touched on? Please. Okay. Hang on a second. Actually, we had a plant in the audience. I'm going to ask John Ruggie to stand up, as he was called out before, and then Don, you're next, and anyone else come and line up at the mic, and we'll ask you to make your questions somewhat brief, so we can get through as many of them as there are.
You didn't tell me brief.
Sorry.
Is this working?
Is the mic?
Working.
I think this is where
It's
we
working.
say, this is where we open the floor to short speeches disguised as questions.
Yeah, that's right. This is where I also do my Marlon Brando mumble imitation. But anyway, I just learned a few days ago that instead of dealing with carrots and sticks, Troy, it's possible to use carrots and frozen carrots. But we just say, as everybody here has said and knows, I think we do have a once-in-a-lifetime elegant opportunity for transformation of the healthcare system. $8 billion from district we're never going to see again, to go from volume to value. Another $150 million to redefine advanced primary care and make it go, and a shared understanding we need to invest in primary care to make the whole thing work. So we've got the biggest simultaneous opportunity for amazing transformation or amazing embarrassment. And I think we can all think of many, many risks about why this may not work. In no particular order, I made a short list. We don't have a primary care pipeline. We don't have transparency, so people don't even know how to seek affordability. We don't have a cookie cutter for primary care yet at Hudson Hill Waters. We're not sure what we're doing is working and what isn't working. We're very, very primitive state of the art. But the risks that I see are really major is so much attention is likely to be placed on crisis management with DSRIP, meaning hospitals are failing and how to shore them up, and not on opportunity management on how to invest sufficiently in primary care. And secondly, DSRIP is all about Medicaid. And if we only invest in Medicaid, we don't have the critical mass to flip the switch from how do we generate more volume to how do we create better outcomes. So the conundrum is, how do we get sufficient investment? And to my mind, that can only come by matching Medicaid investment with the private payers. And so the question I have is, what does everybody, including Troy, think Troy should do to be sure that we have that private commercial insurance buy-in and pay out as an investment?
Well, I'm really interested in any ideas. But I can tell you what we have been doing, which is, you know, Hope and Foster and the rest of the team, we've been meeting with payers, you know, insurers all around the state with our partners at the Northeast Business Group on Health. We've been meeting with payers and getting into really detailed discussions about, number one, because payers are doing various forms of patient-centered medical home and primary care support, many of them. And what are you doing, but also what can we do? How can we make this work? How can we get your buy-in to what it is we're proposing to talk about? And I think we're getting certainly a lot of general positive feedback, but we do need to kind of make the rubber hit the road pretty soon in terms of, you know, specific commitments. So we've been trying things like really explaining and developing the ROI, the return on investment, the case for it. What's the business case for why this is going to work? And also offering up frozen carrots, things around rate review that will let them count practice transformation and care coordination payments that we can offer up. I know we have a lot of different other ideas that we've been talking about internally, including things like we have a very powerful tool in network adequacy review. Mm-hmm. So we, as regulators, review insurers' networks to see whether they're adequate, and we can set those standards. And so what different kinds of mix you might have in order to have an adequate network, something we've just begun to discuss in general. But I'm interested in other ideas that folks have, because we're still in the process of this.
Every year, every quarter, Doofus has to collect financial statements from every insurer. You said it, I didn't. From every, although OHIC doesn't, which is what we were calling Rhode Island, sounds like we were drunk or something. We didn't do any better there.
OHIC.
OHIC.
How many hospitals do you have?
So we got, every quarter he's got to collect financial statements from the health plans around how they're doing. And every year he's got to collect an expanded annual statement. Most of the contents of those statements have been standardized by the National Association of Insurance Commissioners, and then he has the ability to customize, to do appendices, to collect attachments. I would suggest that you get some resources, maybe do it with the health plans and come up with a particular attachment, a financial reporting statement, at least annually, maybe quarterly, on primary care. What did they just bucket it out by different categories? What did they spend? Come up with some definitions for patient-centered medical home. Create a race to the top, and then release that report and have someone say, "Well, I spent more on primary care than that." Well, then show me. And public reporting for health plans are on their primary care spend.
Chris and Troy, do we care what setting? Do we care where it's going? Like if they're spending X% on primary care, but 80% of it is going to primary care physicians employed by hospitals. Is that something we care about or not?
So that's what you
Let me say one more thing about that. Because I mean, what's happening now is the small primary care practices get paid diddly by the health plans, which in the long run, of course, will lead them to sell their practice to the hospitals, and then the health plans will have to pay higher rates. But in the short run, I think the health plans care. But do you guys care, not just about what % goes to primary care, but to the
Well-
type of organization it goes to.
No, I'd say in the short run, the health plans care. They know that the effect of hospitals buying is going to be that they're going to be paying more for it.
But
And so,
they're still shortchanging the small practices.
yeah, because they
Collective
don't.
goods problem.
Right, they don't want to give the hospitals any more than they have to. They got, to Lindsay's point, they got the market power. I think the finesse way to answer that is you collect information on it and you report both ways. You don't do a value judgment at the beginning. You just report out, and maybe you do a special study to look at the rates that are paid for hospital-based primary care docs as opposed to others. But you collect the data first, both ways. You avoid the value judgment to say this is better than.
Yeah, I get it. Is that something that could be done in New York State, Troy?
As always, every time I meet with Chris, who's been a mentor, I get a new idea. So I'll definitely look into that. I think it's a great idea.
All right, I think we have our first promise. So
No. He was. I'm not setting them up.
First promise to look at
at
it.
it.
He didn't say he'd do it. This is just all in the question of what should Troy do, which
It's a
is really
good-
the
it's a
title
great
of our
idea.
activity here. Done. What can we?
I know you didn't want to focus on DSRIP, but DSRIP is the transformative agent of money that's necessary to move away from fee-for-service medicine to value-based payment. And if you know, as I do, the Jason Helgerson presentation where he basically talks about the transformation of Medicaid by getting to value-based payment, that's the model. And the question is, how do we make it happen? Well, in the case of Medicaid, as the insurer, basically, the main goal in my mind of DSRIP is an enhanced primary care delivery system with a care management infrastructure which will result in a 25% reduction in hospitalizations. And so if the hospital providers, who are the leaders of 24 of the 25 PPSs, aren't able to share in the savings by having a partnership with the insurance companies. And in my mind, the value-based payment model that Jason Helgerson's referring to may be focused on Medicaid, but it needs to apply to all the insurance, including commercial patients. And so when you say, Sherry, that an investment in primary care doesn't have a return, I don't agree with you, because the return is in enhanced primary care, which reduces unnecessary emergency room visits and unnecessary hospitalizations. And the primary care doctors have got to be financially incentivized against those quality standards. Otherwise, you don't have the empowered primary care delivery system that you need to achieve these goals. So I don't know whether I can turn that into a question, or you can react to what I'm saying. But if Jason doesn't insist that we carry out that paradigm and that money gets spent to underwrite losses call it in the care delivery system, and doesn't enhance the primary care delivery system and create a shared savings model with the insurance companies, we're missing the opportunity. I'm sorry, go ahead.
I mean, I don't want to disagree with DSRIP. There's a particular issue on the line around DSRIP. We made a deal. That's the deal we made. We have to do whatever we can to make the deal work. So I'm with you on that. That's a somewhat different point than I was making. I mean, this is an argument health economists have actually been having for about 40 years. It started with prevention. And it was always argued that the reason we want to invest in prevention is because prevention saves money. We now have 40 years of studies that show prevention does not save money. Prevention is cost effective, but it does not save money in general, okay? So if we want, we think, the orthopedic surgeons don't say orthopedic surgery saves money. They say orthopedic surgery fixes your knee. We can't sell primary care forever on the basis that all it's about is saving money somewhere down the road. That's not to say that there isn't money to be saved, that we can't improve primary care and cut down on unnecessary hospitalizations. We're at a margin now that there's probably plenty we can do. But in the long run, it's not a viable business proposition for primary care to be entirely about saving money somewhere down the healthcare system. That's what I would say.
I think that's
like the same way as it isn't for prevention. I mean, if that's what prevention is about, we should stop doing prevention because it doesn't save money. It costs money. But we all want to prevent disease because disease is terrible to have. That's the reason we do prevention. I don't know. I mean,
So
it's
Troy, do you disagree?
Smoking
How
costs
do you
money.
react to what I
Smoking
said
saves
about?
money. Well,
yeah, definitely.
I think if I understand it, the point that you're making, which is also Dr. Ruggi's point to some extent, is the value-based payment reform movement going through Medicaid needs to also apply on the commercial side as well, and don't disagree. And we've been part of the value-based payment discussions. We meet with Jason regularly, and I think what we're looking at is making sure that those reforms are going to make sense in the commercial context so that we can apply them in the commercial context eventually. I think certainly what we've heard from a lot of providers is we need to kind of take it one step at a time with dealing with Medicaid first. So, but I don't think there's any, I'm not aware of any intent not to ultimately go with value-based purchasing on the commercial side of the world.
Right, so I just have to ask one more question. The PPSs are hospital-centric.
Yeah.
In my mind, if the primary care docs are not empowered and not financially incentivized against the standard of goals, we're going to miss the opportunity. I don't know if you agree with that, but I'll leave it at that.
Well, I think that, I guess what I would say, thank you, Don, from the PCDC point of view, and as those of you know, Don is a board member of PCDC, so he's been very active in this regard, but we've been promoting the concept of a primary care plan for all of the PPSs, and the whole point of this is actually to monitor exactly what's happening with the primary care investment of that $8 billion and the additional capital monies, and we would hope to do the same, I think, with any attempts at advanced primary care and other things to really understand where we now and to monitor that going forward so that we can make sure that we can actually show that that investment is happening, and if not, then we can retool it in the process. So I think it's a pretty important point to make sure that primary care is at the center of the DSRIP process in addition to the other processes. I think there's a lot of discussion and controversy about this from primary care providers around the state, but I think that it's our intent to try to figure out how to support monitoring of that so that, as Chris pointed out about in general, we want to say, like, the data will speak for itself, right? That will show us whether it's happening or not, regardless of intent, really, and that's where I think we need to go.
Yeah, so usually I give medical advice, but I'm going to ask for political advice from you, and that is, how do we change the policies around funding training for primary care? Right now, if it's hospital-based, it's very efficient for hospitals. They get a lot of cheap labor, and the attendings only have to supervise them for an hour or so a day. It's very expensive to train primary care physicians in ambulatory settings. So what's the fix for that? How do we create a model and have it sustained with, currently all the money goes through hospitals for training physicians, basically.
Any thoughts on training?
It has to change, and I defer to the economists.
I mean, there's so many things in our training system that have to change. I got myself in enough trouble tonight. I'm going to stop.
All right, so we need to train primary care providers in right there in primary care settings so they know what it's about. I think that's really important, but there are many other things as well. So we only have a couple minutes left on this. I wanted to see if I could get through a couple good questions.
That puts a lot of pressure on me.
It does, actually. Brief.
Okay. I work for a federally qualified health center, and social determinants of health are an issue for us. I'm sure we're not alone there. A lot of what needs to be accomplished in value-based payment reform has to do with, having, a degree of a robust civic infrastructure, whether it's food security, transportation to what's needed. We don't have any clear, clinical jurisdiction there. So that's an issue when we are making a major change to change how we're being paid for things. It's an unfair question to say, especially at this point, what do you think about that?
Yes.
But the more concise question, I would say, is there anything in the works or talks about the way we are being compensated for when we are being reimbursed for the care that we give?
Well, to do value-based purchasing, when it involves real dollars and not paying any attention to the socioeconomic status of the patients that an organization takes care of, is a real problem, I think. And I was on a committee for national NQF about should quality measures be risk adjusted for SES or not. Big fighting and basically a cautious yes. It's a complicated issue, and we could spend a whole night on that, but just ignore it is going to really hurt providers that take care of socioeconomically disadvantaged patients, and it will increase disparities in health status then.
And the state did have a work group, and the work group made lots of recommendations, so let's hope they get adopted.
I don't mean to be glib, but one of your colleagues in another health center said one of the vital signs that he checks for is to make sure that his patients are registered to vote.
Amen. Praise God.
I mean, I think we have to be careful again that the primary care system not be tasked
Yeah.
with dealing, being the ones who are going to fix the social determinants of health alone. This is a complicated social issue, but I think that's the same thing. Even with an additional $8 billion, there are many complicated issues around this. But I do think that primary care providers are being asked to report on, to look at, to think about social determinants of health, and I think that's important. But we can't think the primary care system is going to, fix. So that's a tricky problem. All right, we're going to take the next two questions, and then I think we're going to be done.
Okay, quick one. So I'm a medical student. I've been doing it for about 6 months now, and I am really surprised.
Welcome. We're hoping going into primary care.
I have this idea that I would like to do primary care, and I experienced a lot of financial pressure, peer pressure, institutional pressure to maybe reconsider this decision. So I'm wondering if you guys could comment on any policy ideas you might have that would maybe incentivize students to go into primary care.
This should be Larry.
Larry, I think
Larry.
you got any advice for helping a struggling medical student here?
I mean, there's two main factors, I think, right? One is the huge discrepancies in pay. So I don't know if you guys talk about the road yet? Have you been in medical school long enough?
Not that long.
Yeah, the road is radiology, orthopedics, anesthesia, and dermatology. Right. Ways to make really lots of money. People also talk about the rape physicians, right, which is another route to make a lot of money. So that's one thing. There aren't that many students that will just ignore a 5 to 10-fold discrepancy, and especially with the loans they have to pay back. So that's a factor. The other is the culture. At medical schools in a place like New York City, primary care is not valued. You're not specialists or esteemed. So we used to have, I was in California, we had Stanford medical students. They had a required primary care clerkship, outpatient primary care, which was good. You'd think that would be good. And it is true. They were all going into specialties, And I remember one in particular came in. He's a third-year student. He wanted to be a neurosurgeon. And he was clearly bored, and why do I have to spend a month seeing these stupid primary care physicians take care of people's runny noses, right? But by the time he'd been in our office a couple of hours, his eyes were like saucers, right? He could see, wow, this is really interesting, but this is really hard. But in no way did that make him want to do it. You know what I'm saying? So this is going to be, as long as we have the huge, there's a cultural prestige difference and a pay difference. And we can change the pay difference. The prestige difference is going to be harder to change.
So I think in this room, there's probably a lot of people who might be interested in, mentoring. So, stick around after.
But let me just say one other thing. Despite all the kind of griping here, if you like to take care of people every day and really get to know people and and know them for a long time and help them in ways that we're not even talking about tonight, but you can do it all day with multiple patients, it's a great thing to do, despite the fact that it's a hard life and not a very financially rewarding one. So stick to your guns if you're interested in it.
Gary, so I think you're our last question.
Okay, so it's got to be that good. So I'll be a little provocative in this. So my name is Gary Jacobs, and I'm on the board of PCDC, and I won't tell you about my background, except I don't live in New York. I live in D.C. So here's my experience. Medicare Advantage, primary care, value-based care works, and if you put the measures as reducing readmissions, reducing ER visits, and quantify them financially, we can show that there's a model out there that is working, and the difference is that there's much more money involved in a Medicare Advantage member than there is in a Medicaid member or even a commercial member, especially when they're self-insured. So there's a challenge here as to when I listen to what we've been talking about, and you exclude a Medicare Advantage part of it, which is now, 30% of all Medicare beneficiaries, it's a big, big factor, and that's a place where there's enough money where primary care physicians can really be liberated to do what you've described. And the delegated model from California is working in places like Houston, Miami. I mean, it's all over the place. And they're thriving in that model. So there is a model, Troy, that does work, and there's learnings from it. And I just want to kind of put it out there. And there's a lot of literature on it that you probably know about, and hopefully you know about it.
I'm glad you said this. This is actually a really important point. If this is primary care physicians' own fault, if you can band together and get Medicare Advantage contracts, you can take great care of patients and make considerable money. So there's actually a group called New West in Colorado. It's about 80 primary care physicians. They do almost all Medicare Advantage. They actually have very high rates of pay, and they take great care of their patients. We actually just published an article on the large primary care groups in Annals of Family Practice. It's one of the groups we talk about. But this is just primary care. This is nobody's fault but primary care physicians, right?
Right.
Anybody could, in theory, do what New West has done. Get 50 physicians together, primary care, get Medicare Advantage contracts, direct your referrals to the right specialists in hospitals. And there's a lot of money there, unlike in Medicaid, where you can do, or commercial, where you can actually do very well. So that's a point that's well worth remembering. And this is not policymakers' fault. It's not specialists' fault. It's primary care physicians' fault for not doing what New West does, for example.
Well, I think they've also been challenged entrepreneurially to kind of move forward in that chain, and others have jumped before them.
Yeah.
But just to not take that into consideration in this conversation, I think we would be remiss.
Yeah.
So, I mean, I would only just say one thing. One of the reasons that you can show some savings in a Medicare Advantage population is that you're starting with a very sick population. So you have some hope of saving money on referrals and hospitalizations.
Right.
It's actually a lot harder in a commercial population. So that's part of the reason that you're not going to make exactly the same
That's
kinds
right.
of
And
deals.
the mantra in California in the 90s, when the big groups were growing and making a lot of money, so Healthcare Partners, I knew them when they were 20 physicians, and they
Right.
were sold a few years ago for $4.4 billion.
Right.
Their whole strategy was break even on commercial and make money on Medicare Advantage, right? And that is still open to primary care physicians if they would band together and do it. But it's easier to sell your practice to a hospital when the pressure gets too hard. You know?
So I'm going to have to wrap up at this point. If there's any final thoughts anyone on the panel would like to make, this would be a good time. Otherwise, I'm just going to try to sum up very briefly. I think that there are some, as we move towards the utopia that Larry described, where we essentially provide our primary care physicians with sufficient resources to take care of us as a population, until we get to that point, there are some things that we can do in the meantime. We can do some regulatory activities. We can think about how primary care providers can work together to compete better in the marketplace. We can make sure that the requirements in one program, whether it's in Medicaid, for example, are required in other programs that are funded publicly or that are regulated publicly. We can measure, not necessarily adding new measures on, but we can actually look at financial reporting and other reporting, and we can make that public so that it is transparent, so that sort of purchasers and consumers, and others and systems can look at that. And I think your point, Chris, was very well taken, is it can be a race to the top. Everybody can say, we want to do that. Oh, you provide 10% of your spend, 11%. Oh, we can do 12. And I think that those are things that's the positive competition that can happen at this point. Recognizing that there isn't one fix that can that there's a moment here. I think Don is right. There's a moment here of transformation. But we need to be very wise about it, and we need to be somewhat skeptical about it, and we need to be careful about it, and we need to poke at it and make sure that it lives up to the expectations that we have. Because at the end of the day, those are all very important things. But let's also remember what Sherry said, which I think is critical, which is that primary care in and of itself is actually a public good. It is something that we all need, we all deserve it, and that we need to fight to make sure that everybody has access to the highest quality primary care possible. And for that, we need your medical students to become primary care providers, and we need some regulatory reform, and we need FQHCs to be the best they can be, and we need research to make sure that we're we're showing the things that we think that we would like the evidence to show us that we're actually doing that, and that we look to the health economists to help us figure out what are the right incentives, how do they work, and in what way are they best structured. So with that, I'm actually going to let you go. I want to thank everyone who came tonight. We actually have some wine and cheese out there for you to spend some more time. We want to, again, thank Athena Health, Sean Lane and Joe White, and Consumer Computer Specialists, Dennis O'Connell, Marianne Benzola, and Rick Rand for their generous contributions to enable us to be here this evening. And I want to thank the panelists who have given very generously of your time, not only today,